In all the reconstructions, I've adopted the word PACE as an assessment of outcome. And it's not a bad baseline in which one can look at the overall success rate. I use P to reference the word pain-free. They're pain-free surgical procedures. The somatic supply is intact, but like any surgical wound, which is numb on either side and for 3 months for repair time, if it's an islanded, the pain is there and the patient only feels tightness but doesn't feel pain. The asthetic results are acceptable because it's quoting the Gillies concept of the next best tissue is the next best tissue, and the dermatome is the supply line. The purists say, why don't you use a Doppler? I said, there's no point in my using a Doppler when I haven't used it for 3,000 cases. Why do I start now? The vascularity based on the principle that if there's a nerve supply in that markout, there must be some collaterals. Yes, deep down you can put angiographic evidence to get the main supply, but it's the fine collaterals that come from those perforated bases which must be the basis of our success. I also do not like the propeller type flaps, because propeller type flaps skeletonize the axis. And if you skeletonize an axis of a perforator, it will kink. And that's why we quote Robson and all the rest of it around the world, a 46% failure rate of some of these absurd things bent at 180 degrees because there's no protection around the tubing. How does a gas fitter bend a bit of copper pipe? He puts it around a plastic sleeve around it and gets a gentle curve. If he bent a copper pipe on its own, it would kink in the center like a garden hose. I think the perforator system, leaving those areas of a third attached and not skeletonizing, must allow lymphatic units or autonomic units to still be there in perfusion to allow subsequent penetration and performance presence at the distal island flap. Thirdly, complications are minimal. My main complications are not vascular. There's 2 or 3 vascular complications on the dorsum of the foot and diabetes, yes. But the main complications are when the wound is prematurely dressed and the tension sutures are taken out early. I have a rule with my repairs. I do locking mattress sutures for the main tension points, which stay in 3 weeks. Some ordinary mattress sutures that stay in 2 weeks. I do a running continuous to give epidermal apposition to give perfection, and they're cut at 1 week. And of course, don't forget old Benjamin Franklin said years ago, time's money. And if one can get into the system of doing this, it's fairly expeditious in the closure as a reconstructive art.